Welcome to the LowCarbMD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Hello and welcome back to the LowCarbMD podcast. Tro, we've done it again. We found another smarter doctor than us. We're doing pretty well. Our streak is still going, man. It's pretty good.
Yeah, no, we got like 200 smarter doctors than us by now, I think. This is going to be an exciting one. We got another like rebel. If you're not following him on social media, I highly recommend it. If you haven't seen his lectures, go watch them. This is Dr. Pran Yoganathan. He is a gastroenterologist. He practices. Wait, I know you went to medical school in New Zealand. Are you practicing in New Zealand or Australia?
Practicing in Australia, Tro. So been here for the last 20 years as a doctor.
Got it. Okay, so he went to med school out in New Zealand. He's basically been in the. There's a couple of good Australian doctors we know actually, but he's been practicing as a gastroenterologist. He has a clinic. He's lectured on nutrition. And look, we're happy to have you here. We're happy to talk about, we're happy to talk some shit, So since you're a GI doc, I guess we can start with a shit joke. So
absolutely,
we're happy to talk shit.
Oh yeah, we're taking a lot of that lately, Tro. Man, I'm so happy. This is great.
So how do you get started in? I mean, I've seen your lectures. You focused on you're a big proponent of real food eating. How do you go from modern medicine to wait a second, maybe food is medicine, and let food be thy medicine? How do you go there? Because that jump is not something most doctors make.
Yeah, thanks, Tro. I'll give you a little bit of insight about myself and how I kind of fell into all of this. I've always been a mathematically minded person. My granddad was an engineer, and I'm very similar to him. I'm a very objective person, and I've always kind of really understood mathematics well. So I fell into medicine, if I can be honest. It wasn't something that I sort of set out to do, but I've got some very strong cultural pushes, especially from the Southeast Asia. Medicine's a very prestigious thing to pursue, so we've got parents that kind of pushed us down that pathway. And I was a talented mathematician, but fell into medicine. But I was in university at a very early stage of my life, and a lot of what they were teaching just kind of didn't gel with me, didn't make sense for an objective mind or a mathematically inclined mind. So here we are discussing, that modern illness is a product of the way we live and move and eat, and yet just very little attention was paid in medical school during these formative years where it's really critical to understand illness and what causes it and how to treat it. Yet there was no attention paid to how to reverse it through just lifestyle methods, basically. So I've always kind of struggled with that concept, and I think when you're in medical school, you just got to fall into line. You've got to pass these exams. You got to kind of just toe their ethics and their mission statements. So I did that. But as a specialist, once you're out, you've got a little bit more freedom to practice the way you want to practice, and that's where I've ended up. And additionally, like, we've got a good network around us globally, people like yourself and Sean Baker, Ted, like really, really good guys. So I think that gives people like myself the confidence to practice, to know that there are others out there kind of doing some very similar things. I mean, it doesn't mean to say that we all agree on the same thing. I know there are nuances and differences, but there's a community of us. So I think that incentivizes me to kind of practice the way I do.
So what was your first exposure? Is this something you said you were interested in math and you're interested in, and medicine wasn't your first calling, but somehow you ended up here. I mean, how do you go down the nutrition rabbit hole? I mean, I guess as a GI doc, maybe it's better suited. You're probably in the best place to understand nutrition, absorption, liver health. I mean, the list goes on and on. But I know plenty of GI docs who couldn't care less what somebody eats. So, when did this, when did it kind of come into your thinking that, hey, look, I should be focusing on the whole person? Because I know what it's like to go through GI residency. It's, a lot of colonoscopies and a lot of liver disease and a lot of, hepatology. And so how do you get there?
Sure. So a couple of situations, and I'll tell you the first one. I think it was about 5 years ago, and we went to a meeting on fatty liver disease. This was amongst other gastroenterologists in my core group in the hospital. And I remember sitting there and listening to them talk about a new medication that was being brought onto the market that had shown some efficacy in not reversing fatty liver disease, improving it by a very small margin. I think the cost of the drug to implement was many tens of thousands of dollars every year. And when you think about the burden of fatty liver disease, just from a global perspective, I mean, you can imagine the cost to implement it. And I looked around the room at the gastroenterologist, and all I could see was metabolically unhealthy individuals. We had a drug rep lunch or an afternoon tea at us. It was white bread sandwiches and fruit juices and Coca-Colas. And I thought these individuals really don't kind of understand what the basis of fatty liver disease is. And I think I pointed it out at the meeting that, guys, instead of discussing a new drug, which economically is just not viable to implement from a population-based perspective, why don't we look at lifestyle? And I wasn't quite laughed at, but there was just stunned silence, and it was not something that they were willing to embrace. And I think that triggered something in me in the sense that I want to do things differently. So that's one very key moment for me. And the second perspective is also, and this is your American College of Gastroenterology, the ACG, they've put this data out, 75% of presentations to a gastroenterologist private clinic in rooms is related to irritable bowel syndrome. That's the 75% of what we see. And I'd agree with that. I think that's probably about the numbers that I see. Of that 75%, 99% of their irritable bowel is caused by some sort of dietary trigger, which is an insane statistic. Essentially, irritable bowel is related to diet. And we started noticing very quickly when our team of dietitians were implementing these low carbohydrate diets, people were seeing these insane improvements, not only in their gastrointestinal or IBS type symptoms, but also just overall metabolic health, which led me to the conclusion really that gastrointestinal symptoms and metabolic health cannot be separated. They're one and the same. And I've often said to a lot of these younger patients that present to me with IBS or irritable bowel syndrome, perhaps irritable bowel syndrome is actually metabolic syndrome in evolution. This poor gut just basically giving this person a warning signal that, listen, I'm not happy with what's going in. But the paradigm that we currently use in gastroenterology is go and see a dietitian, do a low FODMAP diet. These low FODMAP diets are very difficult to follow because they tell you to cut out all these carbohydrates. Not once do they tell you to increase your intake of animal source proteins or proteins and fats. They essentially say, cut out these carbs. So, well, what's the person supposed to do? It's a very restrictive diet and people can't adhere to it. And when they fail the low FODMAP diets, we use antispasmodics. And the saddest thing of all, we use tricyclic antidepressants and SSRIs in the paradigm to treat irritable bowel syndrome. So none of that's ever made sense to me. So we're trying to do something very, very different. But I think medicine needs a bit of a reset in general. Whether that reset will come, we can discuss during the length of this podcast, I suppose.
Yeah, I'm 100% agreement. I think there's so much. And I think the other factor, if we say 99% of it's our diet, stress, lifestyle, sleep, all these other factors that play in that we're not really addressing. And you know, people coming with ulcers and stress related disorders that they never say, hey, how's life? They just go, oh, you need a proton pump inhibitor and you need some, you know, back in the day, Zantac before they started taking off the market. And, you know, so we start looking at this and not saying, hey, how's life going? Oh, you're going through a divorce? Maybe that has something to do with it, right? All these kind of other factors that we don't really look at. Absolutely.
Couldn't agree more with that. And stress plays a massive role in terms of the gastrointestinal system. You know, we've got the enteric nervous system of the gut, and you've got the central nervous system. a few billion years ago, they're one and the same. They separated. And, you know, it's interesting, the brain and the spinal cord, the central nervous system, is a product or originally derived from enteric nervous tissue. So it's really one big organ system. And you find that when a person's gut health isn't great, generally the central nervous system doesn't function well, and vice versa. You know, if you're not doing well from a mental perspective, the gut system doesn't function well. So you'll find a lot of these tricyclic antidepressants, SSRIs, the clozapines, the antipsychotics, they have a lot of gut-based side effects in addition to their desired central nervous system effects that we as doctors prescribe them for, because they're one and the same organ. The neurotransmitters that run both these systems are very similar: noradrenaline and dopamine, serotonin, and so forth.
Well, on the massive communication back and forth from the gut to the brain for satiety signals, right? For you know, hunger, all these kind of things that we don't realize. When you short circuit that system and you don't send the message to the brain, they don't get the memo. That causes a total disaster, right?
Absolutely, Brian. I couldn't agree more with that. And that term of satiety is so important. And I see Tro and yourself talking about it, and I talk about it a lot as well. It's fundamentally like we've taken satiety out of the modern diet, and that's the fundamental issue. And we've somehow reversed it to, well, you know, you're just eating too much and you're moving too little. But we've essentially pulled satiety out, and that's a huge issue. And you know, it's a central theme to a lot of what I talk about.
Yeah, I wonder, you know, when we talk about IBS, you know, I think so IBS is, you know, irritable bowel syndrome, guys, and it's basically it can present in two basic phenotypes, I guess. One is a diarrhea predominant, and another one is constipation kind of predominant. It's associated with the feelings of spasm and having some GI upset. I think there's also a tight link with anxiety, if I'm not mistaken, with IBS. But if you ask a typical doctor, what is the cause of IBS? What would they say? Right? They'd say idiopathic, or basically we're idiots and we don't know.
Yeah.
You know, right? So idiopathics, like idiots and we don't know. What is the cause? And you know, what do you think is the cause of IBS?
Yeah, look, Tro, it's a tricky one, but I'll tell you this. I think if we were to just to simplify it without overcomplicating it, I think we fundamentally have selected for strains of bacteria that promote excess fermentation within the large bowel, right? And I think the large intestine is where a lot of this stuff's going down, in the colon. A organ system that fundamentally, like as humans, it's great to have it, but you could take out the colon in a human being and give them what we call an endoileostomy, basically bring their small intestine to their skin where a lot of the waste products come out. And these people can still live and have a normal lifespan. The colon serves a function, two or three functions, it's a reservoir for waste. It's also a place where water absorption can occur. So the colon's very proficient at water absorption. But the third thing, which is fermentation, okay, in particular that of carbohydrate-based products or non-absorbable carbohydrates and fibers are a form of non-digestible carbohydrate. I think there's too much fermentation that's occurring within the large intestine because of the way we eat, because of the way we're told to eat, and also because of the microbiome that modern civilization kind of selects for and that we inherit from our mothers. And every subsequent generation kind of inherits that microbiome, and it slowly degrades over every subsequent generation is my hypothesis. In addition to that, you add in potentially the quality of our drinking water and how we obtain it, the frequent antibiotic use, the pesticides and herbicides and so forth that we're using. We all know that these impact the microbiome, but the fundamental underlying cause is carbohydrate and non-digestible carbohydrate fermentation within the large bowel. And once you've got methane within the large bowel, you fundamentally stun the gut. You slow down what we call peristalsis, which is a movement of the gut. And methane, I think, is a key problem in this. So what you tend to see is once you've got excess levels of methane, people tend to get more heartburn. The methane's a gas that tends to bloat them. That pressures these nerve fibers that send signals back to the brain saying your gut's not happy here. And additionally, the colon slows down. So people tend to get a lot of constipation. It's interesting that they've got these two variants, constipation and diarrhea, but really what tends to happen is they initially get significant constipation, then the pressures build up, and then this fermented mess comes out as diarrhea. So often you'll find that it's not one or the other. It's in fact both. People suffer both those symptoms, constipation and diarrhea. That's actually the commonest form that we see. So I think, like, to summarize that, I think we're doing too much digestion within the hindgut or the colon, which as a species we were never meant to do. We are small intestinal based primates, as in we're supposed to do a lot of our absorption in the small intestine with minimal large bowel fermentation. And that makes sense from an evolutionary standpoint as we move from these indigestible fibers and fruits and so forth to these really quality foods, like nutrient-dense foods like meats and seafoods and so forth. We tended to require less of our large intestine, yet in these last 50 years, 40 years, our dietary guidelines have said, well, you know, even the method that utilizes the large bowel. And you'll find a lot of plant-based advocate doctors pushing that agenda of, you know, more fiber, more plants, which I think is really, really interesting.
I'm in California, we're probably closer. So yeah, that's really important stuff. I think that's one of those things we don't think about because everyone says, "Oh, plant-based is the healthiest." Well, based on what? What's the data? What's the science? And I think when you start talking about this with the GI complaints, and there's definitely correlation with I've seen it myself. I mean, it's been a universe. I would not say universal, but near universal. A lot of mental illness and anxiety and stress associated with the gut problems and all these things we look at. It's like, wow, this doesn't seem like it's a very healthy way to be living necessarily.
No, that's right. In fact, it's quite interesting. You ask a person, and like to your audience listening, you'll find that people that tend to bloat more will tend to get a lot of fatigue and lethargy, and these have been linked, right? Like you can actually you can study this and prove it to show that the people with excess levels of bloating will often get quite fatigued. You tend to see it as a presentation in particular, you know, people have a lunch or something like that at work, and then they tend to drift off or have trouble staying awake. You'll find that on a diet that doesn't bloat you tend not to get that type of symptom. The two are interlinked, 100%. And so I'm sure all that poor productivity and things like that can then drive anxieties and so forth. So we've got to be able to, you know, determine whether there's correlation or causation there.
You know, I've seen, you know, I've seen some fairly compelling data showing an incredible link between anxiety and IBS, right? I mean, like just absolutely incredible. I mean, I think one study showed it was like 70% of people with IBS also suffered from anxiety. And I think the unifying factor here that you know, you kind of hit the, you know, basically I agree with is the microbiome, right? And, you know, there's this is an anecdote. There's a local gym, a CrossFit gym, IFA CrossFit, and they did a carnivore challenge for the last 2 months, right? Who can do carnivore? And I just went in, started talking to some people. Hey, what did you notice? What did you notice? Every single one of them said, you know, I started farting less. You know, like that was like oh my God, I'm not farting anymore, you know? And I thought that was kind of interesting, you know?
Yeah, and I think that's part of it too. And especially if you're digesting higher up in the small bowel rather than digesting everything down in the colon, as you're saying. But also, you know, there was a study they did looking at, because IBS used to be a wastebasket diagnosis, meaning we don't know what's wrong with you. You got IBS, okay, you're stressed out, you're anxious, you know, and they would fit the mold. But when they actually did studies, they would blow up a balloon, have them swallow it. You know, they would have healthy subjects that don't have IBS. They blow it to the same pressure. And people with IBS would be doubled over in pain and miserable. Other people would not notice the same volume of gas that they have in their intestine. But they were saying, look, there's something to do with the nervous system, not necessarily the mucosa that we can see.
Absolutely. Now, that's an important point, actually, Brian. What we think occurs in these individuals, a subset of individuals, and probably it's the vast majority of the population, they've got this thing called visceral hypersensitivity. So fundamentally, they're very sensitive to whatever's going on within their gut. And you have to hypothesize that these people just have a stronger link between their brain and their gut, linked by the vagal nervous system. So that is what we term visceral hypersensitivity. And these are the sort of individuals that tend to respond quite well to antidepressants as a treatment for irritable bowel syndrome, because you're essentially kind of blocking that pathway. I disagree with that paradigm, of course. But yeah, that's exactly what's going on. These people are more sensitive to it than others. And believe it or not, it tends to be, in my experience, clinical experience, young females that tend to have more visceral hypersensitivity. And it's one of these things that becomes a vicious cycle. If you're worried about your gut, you're worried about the bloating, you're worried about the aesthetics of it. Some people feel like they're 9 months pregnant. Literally, that's what they tell me. You can understand how that could trigger anxiety as well, right? So you can't separate all these things out. And we talk about the gut microbiome and so forth, and we can talk a little bit about that further. But if you've done low carb for long enough, you'll know that almost universally, irritable bowel syndrome tends to really almost resolve itself completely on low carb. And at which point you start thinking, well, is carbohydrates the issue? And it makes sense to me that it is, because the low FODMAP diet, which is universally used by gastroenterologists, is a low carbohydrate diet. It basically acknowledges that there are indigestible carbohydrates in our diet that we should minimize to reduce these gastrointestinal symptoms. The failure of these low FODMAP diets is they do not advise the patient what to replace these foods with in a dietary system that says meat and eggs and fish and all this stuff is bad. So it's like, if you're cutting out a key component of these people's diet, which is carbohydrates, and then not giving them something to replace it with, no wonder these low FODMAP diets always fail, universally fail. And I remember as a younger gastroenterologist practicing this way, I felt very, very unsatisfied by that paradigm.
And also along those lines with the anxiety part of it is the stress of not knowing if you can get to the bathroom on time. You're going to go on a long car trip with a bunch of people. Now you feel like you got to stop. Is there a bathroom on the way? And the anxiety that causes makes it even worse. So it's a vicious cycle that people get stuck in. Once you start having bowel problems, it's very embarrassing. If you say, I got to go to the bathroom right now, you have to run in and you can't hold it. And, it's really, really challenging. And, along what you're saying, and I think, Tro, like, we'll go back to the old days when we first started, but we were seeing that people's anxiety and stress got better. And I think if that gets better, and that's controlling part of the IBS, and I think what it's all going to tie back to is the gut microbiome, because changing diet changes the gut microbiome, and we know that.
Absolutely. That's the simplest way to do it. And we've got centers, I don't know if it's the same in America, but we've got centers that do fecal transplantation, where they're taking feces from, what they claim to be healthy young people, and often these people are, I think, on very good diets, often very fit people, probably on high protein diets, frequenting the gyms and so forth like that, and just keeping themselves generally healthy. We're taking stool from them, which is basically derived from how they eat, and extracting the rubbish out of it, and obviously giving them the microbiome via colonoscopy to a person with gut issues, and we're seeing resolution of their symptoms. But we don't tell this person who's receiving the stool how to eat. What is interesting with fecal transplantation is once they receive the transplantation, often their food cravings shift drastically, probably to their the donor of the cravings can become very similar to the person who's donated the stool. Yet over time, these people go back to their usual way of eating, because that's how they're programmed, just by their cravings, and these symptoms come back. So fecal transplantation is quite amazing, but it shows you that food definitely plays a role, and it just makes sense, right?
And the microbiome plays a role in what foods we're eating too. And I think that's an important point, because, like you're saying, if they're looking at people who've had gastric bypass surgeries, people who have balloons, people who are on medicines like some of these diabetes medicines that we're using now for weight loss, and they all change the gut microbiome. And so
Yeah.
is it possible that after you go through a gastric bypass, you can't eat for a few days, you're fasting, you're changing your food intake, now you can't bring in so much processed food and bad food for a while, and your gut microbiome changes and you do better, and then you figure out, oh, I could start sneaking in some of my old food, and I'll start drinking soda, and I'll start drinking these other things, and you change it back to where you were before, and you're back to square one.
Absolutely, Brian. I think you've kind of almost hit the nail on the head. We focus so much on the microbiome, but we've got to move away from that and basically start focusing on what people are putting in. I think from the outset, as soon as we're delivered from our mother's birth canal or delivered by cesarean section, we're already set up to receive a bad gut signature because of the microbiome that the mother carries, and that's generally what we will inherit. Additionally, we go through these cycles of antibiotics in childhood, which are overprescribed. I think, we can all agree to that. Antibiotics are overused now in children and just humans in general. So straight away, modern civilization really selects for a bad gut signature. You throw in the processed food environment to that, you've got a real problem. I think we're hammering the gut microbiome. And one of the key factors that we've got to also acknowledge is the pesticide use, especially with a lot of the wheat-based products. Glyphosate or Roundup is very, you can easily detect it in food sources that we're consuming, and the excuse that's been given by the health bodies is that, well, glyphosate's not a problem. It doesn't actually affect human cells because we lack the stigmate pathway. But the gut microbiome is very dependent on that pathway, and we know glyphosate is inhibiting that. So I think there are all these perverse ways in which our microbiome is being affected. And part of the success, I think, of the low carbohydrate diet is because it's so heavy in animal source foods. We're eliminating that chemical manipulation of food, if that makes sense. So there's many advantages, I think, to a low carbohydrate lifestyle in that regard. I've never kind of knocked carbohydrates as a macronutrient, but I think the modern carbohydrate is a really problematic food source just because of all these manipulations that we're performing.
Yeah, and also the glyphosate is destroying the mucus layer of the colon and other things like some of these emulsifiers and things that, you say, well, I'm doing keto ice cream only. Well, if you're eating keto ice cream all the time with emulsifiers that are causing problems to your mucus layer, that's going to cause some issues also with the microbiome. So there's things that we don't. And the other one that comes up all the time, and we've debated it on this show a lot of times, is, oh, what about diet soda? Is it bad or good? Well, what does it do to the gut microbiome? Now we have data showing it's destroying the gut microbiome. So if you're messing up the gut microbiome, it may not have to do with insulin spiking or sugar spiking or whatever your body reacts. It could be directly in the gut. Plus, along the importance of the gut, just what you're saying is berberine, turmeric, curcumin, these kind of things work in the gut. They actually work in the gut, and very small amounts are absorbed, but we're getting decreased inflammation in the body. We're getting other benefits from working on the gut, and we've missed that in medicine. We've missed that, how important that is.
Absolutely. Sorry, Trey, go on.
Yeah, something as so simple as metformin. We just found out that works on the gut too, Brian. Did you see that? Did you see the study that showed that metformin actually makes you poop out sugar?
Yeah, and
you guys see that? They labeled. Did you see that, Pran? Did you see that study?
Yeah, I did see that.
Yeah, what did you think about that?
Listen, it's interesting. Metformin's an interesting drug. I mean, there are benefits to it, and we know that it's got some data with the longevity and so forth. If you've ever tried Metformin Pro, I dare you to try it for a week or two. What's the gut side effects of metformin? And it's interesting, the more insulin sensitive you are, the more gastrointestinal symptoms you'll have. So it definitely has an effect on the gut. I think it definitely regulates appetite, probably by means of making you feel like rubbish. You don't feel like eating. And probably more complex mechanisms like the one they demonstrated in that study, which I thought was quite interesting. I wasn't aware it did that. And it kind of makes sense as to why it works as a drug. But there's no doubt that if it's doing that, it's going to influence your gut microbiome, you know, and it probably shifts it along a more positive pathway. But I'm not a big fan of metformin, to be quite honest with you. I think maybe as a short-term measure, as people are transitioning their lifestyles, but as long-term, I think it makes sense to eliminate these sort of products. So you just don't know what the long-term data is going to be on that.
Yeah, we've seen the B12 deficiency from long-term metformin use. I think that's commonly been recognized. And you're absolutely right. The GI side effects can be certainly pretty terrible. So when
I think, Drew, I just want to just touch base on one thing before we shift gears. But going back, if we go back, there's studies showing, look, if when you're in your mom's womb, if she's stressed out and eating terrible food and going through a divorce and stressed out, you're more likely to have obesity, diabetes, and all these other problems that we worry about, food addiction problems. Whether you're breastfed or not makes a difference. Like if you're bottle fed, way more likely to have these problems. C-section, you're more likely to have these problems. Early childhood trauma, early childhood stress. So for all of us docs, we've been saying, we're doing these Yale questionnaires, like, have you had early childhood stress? Okay, that's why you're obese. But it could be the effect on the gut microbiome. Plus there's reward systems, obviously, like, oh, you had a hard day, Johnny, here, have a cookie, you'll feel better, right? But looking at the interactions between these two, and also the important interaction in the addiction side of it, is the dopamine release in the brain. And you downregulate the dopamine receptors after eating cookies and donuts and cake and all this stuff. Then you need more and more to get that same effect. Just like if someone's drinking 12 beers a day, one beer is not going to be exciting for them. So that's why some people could just have one cookie, and other people need to have 12 cookies to be happy, right?
Yeah, absolutely. I think that dopamine pathway can't be stressed enough. I think we're really kind of existing in an obesogenic environment, not just post-delivery from our mothers. We're talking about an environment that's really geared in a way to make you fat. Like, people talk about obesity isn't your fault, and in a way they're not wrong, because the odds are stacked against them, really. And we could talk about the food corporations and so forth, and the way they mechanically kind of engineer all of this through advertising and so forth. It's really quite perverse. So, Brian, you could talk for days on that aspect of it.
Yeah, and the conflict of interest, that's what we run into, right? Because they're the ones with the money to sponsor education, all these things that we talk about. So you say, well, how do you overcome these problems, right? When I sat back and, as a doctor with gray hairs practicing for a long time, I was thinking, when Fetke and Noakes went through their trials, I was thinking, what in the world? Like, they're telling people not to eat processed food and they're going to court. Like, that's what we've always done for the history of man until recently, like in modern history. So I said, there has to be more to this story. Now, clearly there's more to the story. There's financial disincentive if these guys are telling people to eat different foods, right? If I'm selling food, I'm not going to be really happy about that.
Yeah, absolutely. And in addition to that, you throw in this modern world, and it's a really worrying trajectory that we're seeing. We're talking about, there's a lot of talk on climate change and so forth, and I'm not a climate change scientist and I can't comment on that, but the real push from that perspective is that we've got to reduce emissions and we've got to reduce our beef intake, and they're talking now about taxing meat in places like Europe, and I think it'll come to America potentially as well, and where we are in Australia and New Zealand. If this is the way the world is heading, it's really worrying, because if we're talking about reduction of meat to help with emissions, then we have to, just to achieve satiety, we have to go towards these highly processed foods, or potentially fruits and vegetables, which have over time just become less nutritious because of modern agricultural methods. So it's going to be an uphill struggle, Brian, and the war on saturated fat is now, which was waged decades ago, is now, it's shifted a little bit. It's the war on meat, and in particular beef. So I'm really concerned moving forward in the future as to how we're going to kind of navigate these stormy waters.
Yeah, can you tell me, what do you think about conflicts? I mean, you've seen, what about ideologic conflicts? You've talked about climate. You've talked about environment, and certainly animal rights. To what degree do you think our current nutrition policy is affected by some of these, potential biases, right? Because honestly, from my perspective, more people should be eating more eggs and meat, right? From a nutritional, from a human nutrition perspective. right? But how do you, but that's not the current message. So
Not
how
the
do you
current,
reconcile that?
it's going to be very, very difficult. So we're essentially, we're bags of protein and fat, right? We're not bags of carbohydrate. We, at any given time, we might carry 0.5 kilogram of glycogen in our bodies. We're fundamentally made up of protein, and this is a building block. It is a building block for us, and this is how we're built. And I've always made the point that most people talk about eating to fuel. Really, it's not about that. We have to eat to reconstitute turnover. Our body turns over protein all the time. We've got to eat to reconstitute that. Now, if we're being told to reduce our protein consumption, and in particular, what we've been told is, well, animal source protein is no longer sustainable, we have to go towards a plant-based protein. There is no doubt, and I don't need to revisit the studies. We all know from a scientific perspective, even the plant-based advocates will probably agree with us, plant-based protein is less, it's less it's not as digestible. There's more anti-nutrients to it. It doesn't lack, it lacks the leucine content, which is the critical pathway for muscle protein synthesis. And in addition, the fate of amino acids derived from plant protein is probably very different to that derived from animal source foods. I think they're incorporated into our bodies differently. So we're facing a problem because we're being pushed down that plant-based protein narrative, and it's quite interesting to me. It is the people with the most, like Bill Gates and so forth, and it's worrying how much influence this guy has on nutrition policy. These are the people that are the people with the most, pushing people towards a plant-based future. And throughout history, Crow, and I've spoken about this numerous times, throughout history, the elites have always hoarded meat, and I don't think the ultra wealthy will ever stop eating meat. I don't think they'll actually eat the stuff that they're promoting or selling. And a lot of them have significant conflicts of interest because their shareholders will own these large companies which are pushing out these processed plant foods as a protein substitute. So it's very, very perverse. And all we can do as doctors in this space is kind of keep educating people about the science of all of this. And I think, ultimately it comes down to the individual as well. Like there are a lot of people that know that eating animal source foods is better for them, but they choose to eat a plant-based way of eating because they feel like they're doing it for the environment, which of course, as we know, isn't necessarily the case. Monoculture, monocrop culture is a massive issue. So to answer your question with regards to conflicts of interest, there's perverse conflicts of interest at stake. There's billions of dollars at stake, and we've got governments that are in the pockets of some of these oligarchs. And
how many people, when you went to that medical meeting, right? How many people, if you go to that medical meeting that you were at 5 years ago with a bunch of GI doctors listening to new drugs about NASH, right? And said, guys, I just want to let you know, our nutritional policy is, highly biased, likely bought out, supported by this kind of elite propaganda. And, your patients can heal with a low carbohydrate approach. How many of them would take you seriously?
Most of them wouldn't take me seriously. It's really interesting. Like you look around the room and you've got people that are doctors, these doctors talking about these diseases such as metabolic associated fatty liver disease, which is what it's called now. Literally, that is the new definition of fatty liver disease. We don't call it fatty liver disease anymore. We call it metabolic associated fatty liver disease. We acknowledge that it is fundamentally metabolic syndrome. A lot of those doctors in that room would be suffering metabolic syndrome themselves. And we're talking young doctors in their 30s and early 40s. So most of them kind of don't understand how to eat and move in a way that promotes good metabolic health. So I would have been laughed out of that room. In fact, I almost was for suggesting it's our nutritional policy that is contributing to it. So you start becoming a pariah within your own network of doctors, which makes it very, very difficult to practice. Often there, a lot of negative comments passed about the way we practice with dietitians and so forth. So really, it's stacked against you. You've almost got to swim upstream against the tide to be able to practice this way. So
Can I ask you a question? Can I ask you another question? Okay.
Of course.
So how many people have you seen reverse fatty liver in your clinic? How many people have you seen with dietary intervention?
I honestly, I couldn't tell you because it's that many, and I can tell you something now. Fatty liver disease is one of the easiest conditions that I've seen largely to reverse. Okay, it is so easy to reverse that, and I see it sometimes within 6 to 8 weeks. You drop 5 to 6 kilograms. It doesn't matter how overweight you are, and a lot of times that fat from the liver is reduced. And fundamentally, what it is just excess circulating triglycerides. I mean, you could almost plot triglycerides and liver fat content on a curve, and it'd almost be linear, because that is what it is. But the interesting thing is, you've got a patient with fatty liver disease and elevated triglycerides, and often their doctors, even hepatologists, like liver specialists, will not make the link. They won't even ask for a triglyceride panel.
They'll tell them to go on a low-fat diet. That's what they're saying. Go on a plant-based, low-fat diet. That's what they're saying to their patients, and they think you're nuts. So I'm telling the patient, look, try this and see what happens. And just to tell you, you're not the only one in the room. Rob Sivas, who's become a good friend of our show here, and me, I was at a medical conference. I was the new kid. I was just starting on a keto. I'm sitting between him and Gary Taubes, and they were talking about NASH, fatty liver disease, whatever we're going to call it, metabolic syndrome related, whatever. And they were talking about this drug, that how much money they were spending on this drug to fix it. And Rob says, that's ridiculous. I reversed it in 3 to 5 days. I said, what? And we all looked at him and laughed. And what drug are you using? No drug, diet. 2 days of keto, 1 day of fasting. That's it, done. In morbidly obese patients, by the way. I'm like, come on.
We've confirmed 3 days. We've confirmed it with ultrasound. Right, 3 days.
And he's done it with biopsy and ultrasound. So when you look at it and go, look, here's what we're seeing, guys. You guys are having horrible success rate. And that's what, part of the reason we did this podcast is we have to change the standard of care, because even if you're right, if you're practicing outside of the standard of care, you get in trouble. Even if the standard of care sucks, which it does. So you look and you go, guys, try it and see what happens. And when you see them start changing diet, and stories like that, when you see it in 3 to 5 days all the time. And I never really, at first, I didn't really understand it. But so many people would be having this right upper quadrant pain and just not feeling great, and like always hurting. And we put them on low carb, and they go, "Hey, that pain went away that I had. It's gone. Is it my gallbladder? Yeah. No, it's probably the stretching the liver capsule from your fatty liver disease that we're seeing. Right? Your gallbladder looks fine."
Yeah, absolutely. And at this meeting, I remember saying to them, people with fatty liver disease don't focus on fatty liver disease. People with fatty liver disease don't die of fatty liver disease. They die of heart disease. And that is the fundamental issue. We've got a situation which is overall just metabolic syndrome. And what our specialty wants to do, what these liver specialists want to do, is separate it out into its own special category and find special medications and procedures to treat that. Really, you've just got to treat the overall person, treat the overarching metabolic syndrome, and the thing kind of just, everything falls into place. And that's the part of the issue with our degree. We're told that a human being is a fragment of many different organ systems, and when essentially we've got to look at the person and their whole situation, both mental, physical, and social.
Yeah, that's all critical stuff. Tro, you have another line of question? I see you getting excited over there, man.
Yeah, no, I mean, I think fatty liver is like, they're talking about a multi-billion-dollar. When you look at these drug pipeline companies, they're talking about a multi-billion-dollar pipeline, and it's so sad when you can see that it's all because doctors cannot motivate their patients to make behavior change realistic and sustainable. And that's it.
I think we're looking for a way to say, oh, you don't have to change your lifestyle. Here you go. Here, take this pill and your fatty liver goes away. Right? Here, take this pill and your insulin looks better. Your sugar looks better.
Absolutely. But like, having been in this space for long enough and working with a team of dietitians, Brian and Tro, and I'm sure you guys kind of see it as well, we find that it is difficult to motivate people. It can be very difficult to motivate people, especially the older they are. Once you start getting into their 50s, 60s, and 70s, it is very difficult to get these people to change their routines, even if they know it's good for them. And a lot of them it can be very confronting for them where they're coming in with this issue and you're telling them, listen, the last 50 years of our dietary paradigm has been wrong. There's some barriers to that there. What I'm finding more and more as I become more active on social media, my profile's getting out there, I'm getting people seeking me out for the advice that I provide. And it's probably the same for you guys, right? Where it's very difficult to take someone who's sort of trapped in the illusion of this, our dietary paradigm is perfect, and give them this conflicting advice. It can be extremely conflicting for them, confronting for them. So we find that adherence and even the willingness to initiate diets can be a big challenge. And I've had the most success with people in their 20s, 30s, and 40s because I just find that they're not as stuck in the routine, and there's an inherent mistrust of authority in those groups as well. So you know, whereas some of the older generations have a sometimes I think a blind trust in authority.
You know what? I got to be honest. I'm gonna go on a 5-minute rant here, and I'm sure all the listeners are gonna be so pissed.
5 minutes, Tro.
5-minute rant. So I don't believe that most people can't make that change, right? We recently had a corporation come to us and say, hey, would you consider an employee, wellness program? We've been approached by some smaller businesses. This one was a bigger business. We have some other bigger businesses that are interested. But anyway, we said, all right, we'll take 10 to 12, right? We'll do a 10 to 12 pilot program. We'll see how people do. And we got over, 100 applicants. And out of those 100, we selected 12, right?
Mm-hmm.
And we thought we could benefit the most. And the results have been absolutely phenomenal, right? These are random people, right? They don't know me, right? They just want to.
Let me do a quick public service. Look, if you're an HR department at your company and you're in charge of wellness, don't do this Biggest Loser diet for a week and say, oh, you lost the most weight in a week, good job, yeah, and you destroyed your employees. Do something like what Tro's talking about. We can come in and we can totally help out people for the long term. Education. I mean, this is one of the, don't just check the box. What I'm saying is I'm frustrated because I know how it is to get into the corporate health and people are just checking a box. Oh, we talked about low fat diet. We talked about vegan. We talked about exercise. Watch your stress level. And then, we checked the box and there you go. Good luck, guys. We'll see you again next year. Like really care about your employees and really invest in this. So I cut into your 5 minutes. You only get 3 now, Tro.
We tracked the results, right? We have, I think it's like 250 pounds lost, right? In 3 or 4 months, right? And that's not even including the family members. The neighbors and the friends and the. I think we're down. I don't know, some 120 units of insulin a day, right? A day, right? And so is it that, we can't, not every patient is ready and maybe some patients aren't ready. I think that's true, but is it more likely true that doctors are terrible motivators?
100%, Tro, 100%. Like, there's no doubt about it. We're terrible motivators. What I'm finding more and more is I'm having to increase my consulting times. The actual time spent with a patient, used to be 15 to 20 minutes to see a new consultation. Sometimes it's taking me an hour to sit down with a person. And every consultation, I try and give a bit of myself with my enthusiasm. I try and display passion, some integrity. We pull up a presentation, we take them through it. But and a lot of people love that. They love it, but it requires so much time to be able to implement this properly. It really becomes a venture for us. For me personally, as a gastroenterologist, I'm earning less than I was 5 years ago, just as a personal thing. But I'm just happier with the way I'm practicing medicine. It requires so much more time. And the issue that I'm facing, if I can be totally honest, is we're giving them this advice. They're going back to their family physician or family doctor that's initially referred them on and telling them the advice that we've given them. And they're fundamentally being told that is not in keeping with the guidelines. So the patients are conflict because they've got a family doctor that they've known for the last 20, 30 years and a young gastroenterologist that they've met for 45 minutes to an hour. So we've got
Well,
that issue there.
Listen, hold
Ron,
on.
I think the question goes back, like, they've been your doctor for the last 25 years. Now you have fatty liver disease and diabetes and all these problems. Maybe we should try a different approach because it's not working.
You know what?
Absolutely.
I think we need a worldwide network of low carb metabolic health focused doctors. Me and Brian have been talking about it for a long time. Hopefully we can execute on it. We have the estimate.
That's the thing, is like, that's the same thing, is like having mixed messages makes people crazy, because they're saying, no, that's crazy. Don't do that. And so people are seeking us out because they're saying, look, my doctors say I'm crazy, but I feel better and my numbers are better and my blood pressure is better. Right. And it's so frustrating for people.
100%, Brian. So that's what it's turning into. My practice has gone from, because they go back to their primary doctors and the primary doctors go, well, that gastroenterologist is crazy. I'm not sending him any more referrals. So we lose referrals from these general practitioners. I've slowly lost a lot of those networks. But what I've gained is general practitioners that agree with my philosophy, and also patients who are connected through the social media network and who are familiar with that low carb world, then seeking me out. So we start slowly over time selecting for a population coming to us that are already kind of initiated that there's something wrong in this world with the way we eat. And that becomes a much more fulfilling thing, because we can help them on the journey, because it is really a journey that you've got to take together for a long time. It's not kind of an overnight process. And even then, after sustained health benefits that people see, people can still fall off the bandwagon. You know, it's a very stressful world out there, and food can be a source of pleasure and a source of addiction. So people can fall off the bandwagon. We've got to be there for them. So this is why I stepped onto social media, because I just found it as a way to kind of shout from top of a rooftop, really, as to what we're doing, what we're about, and slowly over time we're pulling in people like that who are willing to change, who are ready to make that step forward.
Yeah, and I think sometimes you step out there and you go, okay, look, I'm not going to discriminate against you. I'm not going to treat you terribly and all those things. And it's amazing how many patients are being treated horribly. And you know, I'll tell you, we could go into the bigger theme, but I think the bigger theme is a lot of doctors aren't happy, so they're not really, like, patients say, hey, can you order an insulin? No, I'm not going to do that. There's no sense of that. Instead of saying, no, I don't, explain to me why you want it, right? Let me understand it. They just say, no, that's crazy. That doesn't do anything. Well, it tells us a lot of information, and triglycerides, like you're saying, tell us a lot of information about fatty liver disease. But it's interesting how the patients are beaten down. If they say, hey, can I try this? No, you can't. It's dangerous. You have to go by the guideline. You could either be vegan or you could be low fat. Which one do you want?
100%.
But I've tried that my whole life, doctor. It's not working. Okay, then pick the other one.
Yeah. So we've got a cohort of doctors, I think, practicing that have fundamentally fallen out of love with medicine. And I think if you fall out of love with medicine, you're falling out of love with your patients. So it's become, in Australia, in primary care, and I have to be totally honest, it's become a churn and burn model where they've got to get through patients quickly to pay their staff, maintain overheads, you know, and to earn a living. And so it becomes a 3-minute consultations where these patients are in and out of these rooms. Sometimes some doctors are seeing 40 to 50 patients a day. How do you provide quality care in that time frame? I'm seeing 5 or 6 a day, right? And even then, at the end of that, I'm drained because I give so much of myself during those consultations. So that's the issue. We've got an economic environment, and this is why I talk a lot about our monetary policy. We've got inflation, so it's becoming harder and harder for these doctors to maintain practices and maintain their level of income, which is going to translate to poorer quality of patient care.
Yeah.
So you got to.
Which, you know what? Honestly, it's going to make our value go up even more, right?
Yeah,
I mean, that's the sad reality. You know, I hate to say this, but we're more busy now than ever. Yeah. Right now than ever.
You know, you made me smile, Tro. One of my colleagues who was giving me a hard time when I started doing low carb and keto and all that, he had to be the program director at a big hospital locally. I just got a text from him this morning. Hey, several of our residents want to rotate with you because they've been hearing the podcast and I'm like, seriously, I thought I was crazy. You're going to send your students to a crazy person over here? He goes, well, you know, a lot of your stuff is panning out. We'll take it.
Yeah, I think paradigm shifts require people to lead from the front, and, you know, a lot of admiration for what you both have done. You both have led from the front. You've been in the low carb world for a long time. And I think eventually over time, you do see that shift occurring. And but it's going to take many years. And I think a lot of these medical students, people are connected now. People have networks, and social media is such a powerful tool. You'll find that change is not going to come from the older generations of doctors that have been practicing this way for 30 to 40 years, but the newer generation of doctors waking up and saying, listen, we think there's something wrong with this, and that's how we're going to do it. We're going to follow these sort of guys and do it that way. So we
he looked at me when he said old throw, and he looked at you and said, yeah, I don't know,
when he said newer generation, he was definitely looking at me. Okay, definitely looking at me.
We need the dinosaurs to die out, I think, and that's the sad reality, because a lot of them aren't open to change, and nor are they passionate about what they're doing. I think
they're going to burn out. They'll burn out.
Here's the problem: the young ones are blind automaton lemmings, right? That's the other side of it, right? When at least like the older ones have, some wisdom, right? It's like really some of these young people coming out of training, right? I asked a question to a group of 100 medical school students, and I said, what drugs lower mortality in MIs and heart attacks and acute coronary syndrome? And I got a bunch of like dumb stares at me. And I said, who is Kanye West married to? And everybody said Kim Kardashian, right? Like, what does that tell you about the value of our, upcoming, the young ones,
Us docs we're rule followers. So we just say, oh, you tell us that? Okay, that's what it is. Instead of saying, wait, that doesn't make sense. Why are we giving them sugar and then shooting insulin to get rid of the sugar we're giving them? Why don't we just not give them the sugar and then not have to give them the insulin? So they don't think that way. They just say, well, here's a sliding scale insulin. This is the way you do it. Here, here's the order set. Just stamp this out every time and you'll be able to get your patients through quick. So I think it's a problem we've stopped thinking. And also I think the biggest tragedy, we talked about it a little bit before we started, but I got banned from YouTube for a month or something because me and another doctor, we talked about our clinics and what we saw in the last 2 weeks. And because of that was medical misinformation, right? It's insane because we should be able to discuss something and go, yeah, Brian's crazy. Here's why he's crazy. Let me give you my pointers. But there was no saying, hey, this one thing is out of context or whatever, could be misleading to people. There was nothing. They just say, no, we don't like it. You're out. It's just, and I think in medicine, we've got to that point where you can't question authority. You have to be able to say, hey, this doesn't make sense. I'm doing this and it's working differently. Why don't we try this? Then that's how the standard of care changes. When we say, hey, here's my clinical experience, like Dr. Fetke and Noakes did, and then we can adjust accordingly.
Yeah, we have an overarching body called APRA here in Australia, and their towing lines basically, if you're practicing anything outside of what the public health guidelines recommend, well, then you're practicing outside the norm, and you're straight away you're brought to attention. One of the guidelines, our Cancer Council guidelines, is that don't consume meat or reduce your meat intake to something like ridiculous, like a handful of meat every week, is something ridiculous. So, like, the message that we're giving could very well in the future be deemed medical misinformation. We could be censored on platforms such as this to kind of change our messaging, which is a really concerning time. Like, if anything, the last 2 years has shown us that these powers of control, the tech giants anyway, they fundamentally control messaging to the population. So I'm concerned moving forward in the next few years. We'll see how things pan out.
I got to ask you one quick question before we head out. Okay,
we could do this for 2 hours, Tro.
No,
I got to say one comment. Tro used the F word. He tells everyone in the world off on Twitter. He does all this. I'm like, Tro, tone it down, dude. You're gonna get banned, and I get banned. I'm like, what the heck is this, man?
I must say, I love Tro's tweets. It's just, I love Tro's messaging because it's just blunt, to the point, and just
tells you the way it is.
Keep it up.
We gotta have more blunt. Listen, which one is worse? I gotta ask you, which one is worse? Chronically leaving a patient on Colace, right, for no real reason, or chronically leaving a patient on a proton pump inhibitor for no real reason? Go. Which one drives you more insane?
What, Tro, can you tell me what Colace is? I think the trade name.
It's
the trade name must be
Doku. What is it?
Colostrum. Yep. Okay. Yeah. Look.
Which one drives you more crazy? Or is it equal?
I think proton pump inhibition. You got to remember, like, Colace probably works downstream in the lower gut. proton pump inhibition is, I don't think it is benign as people make it out to be. I know there have been long-term studies that said, oh, it doesn't cause osteoporosis and so forth. But I've got real concerns about increasing gastric pH long-term in a population. I think it has so many downstream effects in terms of our digestibility, what happens in the small bowel, and also what happens in the large intestine. You can putting a person on a proton pump inhibitor will rapidly shift their microbiome. And in fact, a lot of people notice lower gastrointestinal symptoms. So I think we need our gastric pH to be able to digest the protein, to cleave it into its absorbable form. And I think chronic overuse of proton pump inhibition, probably moving forward, I hope is shown to be problematic and also a contributor to this sarcopenia, osteoporosis epidemic that we're seeing. I don't think being on proton pump inhibition ideally allows you to ideally absorb protein, whether that is plant-based or animal source food, in particular animal source food. It drives me insane.
They both
and also the gut microbiome effects are pretty massive.
It's huge. Yeah, I agree with that. I think we're fundamentally causing fragility and frailty by promoting long-term proton pump inhibition use. We've got to remember that when these drugs first came out, it was supposed to be used for 6 to 8 weeks for gastric ulcer bleeds and duodenal ulcer bleeds and so forth. And for somehow it's been perverted into a paradigm which is now, oh, you can be on it for a lifetime. And you see 18 and 20-year-olds with abdominal bloating automatically put on proton pump inhibition. What they should be told to do is modify the fermentable carbohydrate in your diet. And there's this huge placebo effect, 40 to 50% of these effects are placebo, where the patient goes, oh, maybe it's a little bit better. The GP goes, well, improve, stay on it for a lifetime. I mean, enormous cost, enormous repercussions to a population.
I knew I would trigger you with that one. I knew I would get you. Listen, I got 2 quick questions for you from the audience. Guys, Patreon supporters, thank you for joining us and donating. We got 2 questions here. One is, are emulsifiers a huge issue, and what low carb foods could have a high amount of emulsifiers that people aren't aware of? So that's question 1. Any topics on, any comments on that?
Yeah, sure. I've looked at some data with regards to the integrity of the gastrointestinal tract, these tight junctions that link these cells together, particularly in the small intestine. We know that fructose, alcohol, gluten, food additives cause these tight junctions to open up. So the gut becomes more leaky. And I think the internet colloquially calls it leaky gut syndrome. Yeah. We call it increased gut permeability, basically, and you can measure it objectively. I think food emulsifiers probably fall into that category as well. There's some data around it, nothing conclusive, sadly, but it makes sense to me that they might be problematic in impairing our gut permeability. In terms of what foods contain it, generally it's going to be processed foods, Tro, and even in the low carb community, we're not spared from that because there's a lot of processed crap in the low carb world. And I think we've got to be wary of that, especially a lot of these dessert replacements that we've got in low carb. I think it's okay as you initially transition from a high carb diet to a low carb diet to utilize those things. But over time, you want to start moving away from those processed products because it's generally going to be the processed foods that contain a high degree of emulsifiers. Even in things like yogurts now, you can find emulsifiers, which is a real pity. What should be a whole food has somehow become processed by that.
And the second question we got here is, do you think home breathalyzers like the Air, which I'm not familiar with it, are useful tools to assess, monitor gut health? I guess I don't know if it's hydrogen breath testing. I don't really know. That's what they're talking about, I suspect, Tro. The hydrogen breath testing, listen, I never use it because if you're bloating, right, if you've got abdominal distress from increased flatulence, gas, bloating, belting, you're going to have a positive hydrogen breath test. I think you could just monitor your own body, in particular, how much do you fart and how much do you burp, how much are you bloating? These sort of things will tell you how much gas is being generated within the gut, because it's not only methane, I mentioned methane, but hydrogen, nitrogen, there's a whole sulfurs, there's a whole lot of gas that's generated within the gastrointestinal tract.
So if you're consuming foods that are prone to ferment, of course, your hydrogen breath test is going more likely to be strongly positive or be increased. And it's important to remember, even in the low carb world, we can still malabsorb protein and end up with protein putrefaction in the hindgut. So this makes sense for me to move away from processed protein, in particular things like protein shakes, because I think they do have a tendency to malabsorb, and you can test positive on a hydrogen breath test for that because the microbiome putrefies protein, which is not a great way to do it. We're supposed to cleave protein and absorb it in the small gut, not putrefy it in our colon. That's where things go wrong for us.
And Pran, what's your best bet for improving the gut microbiome, nutrition wise?
Honestly, Brian, it's pretty simple. I think your microbiome responds to exercise. There's no doubt about that. I think we've got to move. Yeah, there's data on that. So we've got to learn to move properly, and we've got to eat in a way that allows us to nourish the way we move. So really eat to exercise and eat to reconstitute turnover, not eat to fuel. We've got too much fuel in the world. So really, I look at overall metabolic health, the things that are going to drop your insulin, the things that are going to raise your HDL, things that are going to drop your triglyceride, and things that are going to make you drop visceral adiposity are probably the things that relate to, which are the tenets, the pillars of metabolic health, are probably the things that improve your gut microbiome. In addition to that, I think we've just got to move away from the processed food stuff, which generally tends to happen anyway as you're trying to improve your metabolic health. I think the closest you are to the way nature intended us to eat is probably what is needed to improve metabolic and gastrointestinal health.
Awesome.
Amen.
Thanks, man.
That's it. I think that's it for the question.
Fine, you should be moving to San Diego. We have the same weather pattern. You should move here. I need a good GI doc over here who understands this stuff.
We're flooded out, and I will make my way up to America at some point, and I'd love to meet up with you guys for a low carb meal, hopefully.
Well, you have to come to the better coast, so that's
Yeah. Come to San Diego.
Yeah,
it's nice here.
All right, guys, listen, Dr. Pran, Yoganathan, awesome. Thank you so much for coming. I love your Instagram content. I love your Twitter content. How do people find you, by the way? How do people find you?
Listen, I'm active on Facebook, Twitter, and Instagram, as you said. My handle is Dr. Pran_Yoganathan. I post daily. I try and stay active on social media. Just my thoughts, not just on gastroenterology, but just some of the social, political, geopolitical things that influence the way we eat, the way we move, and the way we're supposed to kind of live. Feel free to follow me, and thanks again for giving me the opportunity, guys, to come on your platform and talk to your followers.
Yeah, it's been great.
So great.
It's been great. Keep it up.
Important. Good stuff.